Hi, my name is Dr. Patrick Yachimski from the Vanderbilt University Medical Center in Nashville, Tennessee. Thank you for joining me on the GIE Author Interview podcast. The study which I'll be talking about today is titled 30-Day Hospital Admission Following High-Risk Outpatient ERCP, Incidence and Analysis of Risk Factors based on a secondary analysis of the Stent Versus Indomethacin trial dataset. I'd like to thank my more than 36 co-authors from an international consortium of endoscopists, biostatisticians, and data safety monitors. The initial SVI trial was a randomized, controlled, blinded, non-inferiority trial of 2 different strategies for the prevention of post-ERCP pancreatitis among high-risk patients. I'd like to extend an additional thanks to Dr. Joel Munzer, the principal investigator for this trial, the results of which have been previously reported elsewhere. The study I'm describing today is a planned post hoc secondary analysis, the rationale for which is the following. We all know that ERCP is a technically complex procedure with a robust adverse event profile, and it's a procedure which is often performed in patients with significant comorbid illness. Given the planned rigor and duration of follow-up of the SVI trial, we felt that this study would provide a valuable opportunity to assess for outcomes and potential adverse events for patients undergoing ERCP beyond the typical window of discharge from the endoscopy suite. So what were the objectives of this study? Objective number 1 was to identify the rate of hospital admission within 30 days following high-risk outpatient ERCP. Objective number 2 was to identify patient and procedural risk factors associated with 30-day hospital readmission. And objective number 3 was to compare post-ERCP pancreatitis rates and length of hospital stay, comparing patients admitted immediately to the hospital following outpatient ERCP versus patients representing with delayed admission within 30 days following outpatient ERCP. So the cohort consisted of patients undergoing outpatient ERCP felt to be at high risk for post-ERCP pancreatitis. High risk could be defined by one or a number of combination of either procedural factors or patient factors. For instance, technical aspects of ERCP felt to increase the risk of pancreatitis for enrollment in this study was difficult biliary cannulation, which was the qualifying criteria for a majority of the patients in the SVI trial and in this cohort. A full list of study entry criteria can be found in Appendix 1 published with this study. We excluded patients who underwent ERCP while hospital inpatients. We also excluded patients who underwent outpatient ERCP at institutions at which routine observation for 23 hours following ERCP for all patients was the standard norm. The cohort consisted of 1,072 subjects who underwent high-risk outpatient ERCP. The cohort was predominantly white, predominantly female with a mean age greater than 50 years, 95% of whom underwent ERCP for a benign disease indication. In fact, obstructing tumors of the pancreas, head, and ampulla were exclusion criteria for participation in the SVI trial. What we found was that the 30-day hospital admission rate following high-risk outpatient ERCP was 21.9%, considerably higher than had been reported in previous cohorts in the peer-reviewed literature. We also found that the 30-day ICU admission rate was 2%. Factors associated with 30-day hospital admission included patient age, a biliary stent placement with an odds ratio of 1.62, and attempted pancreatic duct cannulation with its odds ratio of 1.64. In comparing patients admitted immediately to the hospital following outpatient ERCP versus patients readmitted within 30 days following ERCP, we found a higher post-ERCP pancreatitis rate in the delayed 30-day readmission group, 40.5% compared with 30.9% in the immediate admission group. We also found that hospital length of stay was longer in the patients admitted within 30 days compared to patients admitted immediately following procedure. So how do we interpret these results? At face value, the initial interpretation is that for a substantial portion of high-risk patients undergoing ERCP, ERCP is not an isolated outpatient procedure, but is one episode in a continuum of care. This should inform the risk-benefit analysis in deciding to proceed with ERCP in discussion with the patient and inform the informed consent process. However, there are a couple of important caveats. Number one is that the cohort in the SVI trial and in this study was a cohort enriched with patients with sphincter dysfunction and largely excluding patients with pancreatic cancer. Therefore, the cohort may not be fully representative of a typical ERCP practice. Caveat number two, based on the way the data were collected and reviewed, we cannot ascertain whether the 30-day admissions were directly related to, indirectly related to, or completely unrelated to ERCP. That being said, 40.5% of the 30-day hospitalizations were adjudicated as meeting diagnostic criteria for pancreatitis. Now, what to make of the longer length of stay and more severe disease in the 30-day group? One plausible interpretation that this is a dilutional effect due to routine observation of asymptomatic or minimally symptomatic outpatients admitted immediately after ERCP. However, an alternative explanation is that early admission with early aggressive IV fluid resuscitation, restriction of dietary intake may improve outcomes. I would advise caution in suggesting, based on this study alone, that routine biliary stent placement alone is a high-risk intervention. Perhaps this is a marker of other procedural or technical factors, including difficult or incomplete stone extraction, robust sphincterotomy, post-sphincterotomy bleeding, etc. Nonetheless, we hope that the results of this study are informative and perhaps lead to new investigation to identify potential strategies for close follow-up, observation of patients undergoing outpatient ERCP, and potential novel scoring systems such as biomarkers or risk tools to assess patients in the early post-ERCP period. I hope this is a good introduction to our study and you'll take a thorough read in the journal. We look forward to hearing your thoughts and comments. Thanks for your attention today.